Hi, everybody. It's almost 8 o'clock, so we'll give everyone just a couple of minutes here to log in. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am very excited to have our guest speaker, Dr. Tabor Gray, discussing ALS with us this evening. A couple of housekeeping items before we jump into content. As always, the session is eligible for ASHA CEUs, so tonight's event is eligible for zero point 0.1 ASHA CEUs or 1 PDH. If you would like ASHA CEUs for attending tonight's session, we do ask that you stay for the entire duration of the webinar and that you complete a brief survey. I'll put that survey link in the chat, and it will also be sent out multiple times from Zoom emails. If you do not need ASHA CEUs, but you'd like a certificate of completion, or if you also want a certificate of completion and ASHA CEUs, just send us an email at tims-univ@tims.com and we'll get that to you within 7 days. A note that this webinar is being recorded, so if you miss anything, no stress. This will be up on our website within 48 hours. And then finally, if you have questions throughout the session, feel free to put them in the chat or the Q&A box, and we will address those at the end of tonight's event. So with that, I'm going to hand over the floor to Dr. Tabor Gray.
Thank you, Brooke. And thanks everyone for joining us on this Wednesday afternoon, Wednesday evening chat. Today I'm going to be talking about the role of the speech language pathologist in the multidisciplinary ALS clinic with a focus on using evidence-based outcomes to optimize bulbar management in this population. Here are my disclosures. The overview of tonight's session is listed here. It's also on the website. When you signed up, I'm sure you saw it. But basically, briefly, we're going to be talking about what ALS is and how the multidisciplinary clinic runs, the incorporation of the speech language pathologist into that model. We will get into the available evidence on bulbar screening and assessment tools, ways that we can monitor decline in these functions, try to improve prognostication. I'm seeing that we can't see the slides. Let's try again.
Yeah, sorry, I came back in just to say, for some reason your slides weren't sharing. If you try to click share again, I know it works because you tried it before, but
Yeah. Are we
perfect.
here
All right,
now?
we're good. Yes, we're good.
I was just testing to make sure someone was listening. So mission accomplished. Here we are. So now we can see the slides, which is great. And to continue, kind of talking about the evidence of bulbar screening and assessment, ways to monitor decline and improve prognostication for bulbar function, reviewing a consensus-based model that we're working on, given the evidence that we have, and then concluding with any questions and a group discussion about what we discussed. Learning objectives, again, I'm not going to reread these, but they are listed on the website, talking about ALS and ways to integrate these consensus-based outcomes into our clinical decision making. So we'll start talking a little bit about ALS, getting everyone kind of on the same page of the type of disease that we're dealing with. We know that this is a fatal, very heterogeneous neurodegenerative disease. Recent prevalence has increased, although it is still considered a rare orphan disease. It impacts about every 9 in 100,000 people. The cause of ALS is unknown. 10% is considered familial, meaning there's some hereditary component or potentially some genetic, while 90% is considered sporadic, meaning we don't know the exact cause, although several hypotheses have been borne out in recent years. This is a rapidly progressive disease. Survival is still 3 to 5 years and has been since about 2009 when the last practice parameters update came out. We don't have a cure for their disease, and there is very limited therapeutics. We have a few FDA-approved medications that slow the disease by a couple months, and some behavioral interventions that have shown some good efficacy and been replicated over the years. But everything is overall slowing the disease and not impacting or preventing the disease from starting. So the pathophysiology of ALS, amyotrophic, meaning no muscle nourishment. The disease requires involvement of both the upper and lower motor neurons, and a combination of those results in the disease diagnosis. There are diseases that have just loss of lower motor neurons, like progressive muscular atrophy, as well as loss of upper motor neurons. This would be things like PLS. So the combination of these, it forms the most aggressive and fatal of the motor neuron diseases, which is ALS, and what we'll be focusing on tonight. This results clinically as muscle spasticity, which to us looks like slow movement and hyperreflexia, whereas loss of lower motor neurons results in atrophy of the muscle and fasciculations. And this impacts all components of bulbar muscles and results in dysphagia, dysarthria, impaired cough, and airway clearance. ALS phenotypes, the most commonly known phenotypes and kind of referred to are probably bulbar and spinal. And these are kind of the umbrella terms that we use to describe ALS that impacts the muscles of speech and swallowing, being bulbar onset and being a little bit less common in about 30% of patients with ALS. Spinal onset impacting either the muscles of the arms or the muscles of the legs first, the more common onset occurring in about 70% of people. But recently, probably in about the 5 years, last 5 years, they've recharacterized these phenotypes to involve many different types of onset, which you see here in these diagrams, characteristic of both upper, lower motor neuron, or a combination of the two. And these different phenotypes have different progression rates, with bulbar and flail arm being the most aggressive of the two. So here in this graph, we see the variable site of symptom onset with the little person in blue here. The ALS FRSR score is kind of our gold standard measure of disease progression. And we see that these variable patterns of spread will also have an impact on the rate that the ALS-FRS or functional decline occurs, and also is impacted by all these other things like how long does it take someone to get diagnosed, what region of symptom onset, the age of the person, how they're treated along the way. And I say all of this to say the gold standard of care is multi-interdisciplinary clinics. So here we have a group of up with a person with ALS, living with ALS in the center, and all of the people that are involved in the care. So the multidisciplinary clinic runs about a 3 to 4 hour appointment. The patient, for example, the patient could come in the morning or the afternoon with their caregiver, and they're seen by all of this group, all of these professionals. And that's what's considered a certified treatment center of excellence. And within that time, the goals of the multidisciplinary clinic are to optimize symptom management, slow the progression of the disease, maintain or improve the quality of life of both the patient and caregivers, reduce the burden that is associated with the disease, and also reduce hospitalizations and emergent care. And within the multidisciplinary clinic, while these people are all working together, we of course have very distinct roles. So as these patients come in, these professionals are constantly communicating throughout the course of the day. We round on the patients in the morning and then again in the afternoon. Each provider is assessing their respective domain in terms of physical function, quality of life, and burden, looking at the effectiveness of the current symptom management and also disease-related complications, with a goal of empowering patients through these open discussions regarding their care planning, and of course, opportunities for research participation. Circling back to these certified treatments and centers of excellence, one important note about them is that they have to incorporate some research in order to maintain their center of excellence status, which is a really important thing in ALS because, as I mentioned before, while there are some treatments that slow the progression of the disease, it is really important to incorporate research to make sure we're addressing the most cutting edge treatments. You know, we have some genetic forms of the disease like SOD1, where we have things like Qalsody, which is the brand name for tofersen, that has come to light in the past couple of years. And for that very rare portion of the disease, this tofersen drug has been very effective. So making sure that we're giving these opportunities throughout the course of these multidisciplinary clinics as well as clinical care. So the speech language pathologist in the multidisciplinary clinic is responsible for a lot of different things, as all SLPs are. Our scope is very broad, and we're dealing with a population that essentially all components of our job are impacted at some point throughout the disease. This includes cough and upper airway clearance, oral health and secretion management, communication assessment and voice preservation, swallowing screening and assessment, as well as educating the patient and caregiver about anticipated changes, the rapidity in which they might occur, as well as any prognostic information that we can offer. So it's a very big job for a speech pathologist. We have a lot of ground to cover in a short period of time. And I'll get into some of the obstacles and kind of the best way, well, the best ways that we can target integrating our evidence-based treatments into clinical care, with consideration of being pragmatic and utilizing the resources that we have. And before we get into that, I'm going to go over the evidence. So things that we know to be accurate right now, given the research that's been done, and then how we can incorporate the evidence directly into our clinical care, again, with consideration of resources across these different clinics, time allocation, and the obstacles that we encounter in the interdisciplinary clinic model. So dysphagia and ALS, this is occurs in over 90% of the population at some point throughout the disease. So here, as speech language pathologists, we're very familiar with video fluoroscopies. Here we have a very early diagnosed ALS patient with no visually perceptible impairments on video fluoroscopy. And throughout the course of the disease, we can observe both impairments in bolus efficiency with residue accumulating throughout the pharynx and on the base of the tongue, as well as deficits in airway safety and clearance. So we can appreciate here not only dysphagia, but an ineffective cough response. So this is a picture that we see very often in our patients with ALS. There is an attempt to clear the airway when airway invasion occurs, but that is ineffective. As hard as you can. Good. And having no, professional equipment or experience in rating cough, we can appreciate that this cough sounds a little bit more like a huff, not a lot of high velocity shearing forces going on to clear the material from the airway. And this is why we see this picture in which the sensory response is there and that the cough was elicited, but it was not effective in clearing the airway. So dysphagia and dystesia co-occur in this population, and this is a very common uh, picture that we see. So again, 100% of our patients will experience difficulty breathing, and the vast majority will experience some impairments in swallowing. Here we have a cough spirometry, which is just equipment that we use to measure the cough waveforms. But the point of this slide is to really appreciate the acoustics of the cough. So if we just listen to this cough. Again, cough. Yeah. Not even having the waveforms or any of the professional analysis, and we compare this to his video fluoroscopy. And we can appreciate that bolus efficiency and airway safety here was intact. Cough hard. And we compare this to an individual with an impaired cough. And again, the combination of dystesia and dysphagia is a very common picture. And not surprisingly, the graph in the middle here, we're comparing swallowing related quality of life and the EAT-10, which is a measure of patient-reported swallowing impairment or severity. And the relationship between this is very tight. So we know that as swallowing becomes more severely impaired, swallowing related quality of life also reduces. Another way that we can assess upper airway and cough and swallowing function in ALS is using FEES, which again, this group of SLPs is very familiar with. The reason that we have incorporated these slides is to show you the difference between, to give you a different perspective on the airway. So here we have good control of secretions, good airway protection, good bolus efficiency. And again, when we compare that to
Cough forward.
the airway clearance or the upper airway cough response, which you'll often see referred to as peak cough flow, we can appreciate a good, strong sounding cough. Slightly different picture here. We see a little bit more secretion accumulating in the piriform sinus as well as the vallecula. Slightly more residue in the piriform sinus. A double swallow needed to clear everything. And when we compare this to the cough response,
Cough hard like you have something stuck in your throat.
slightly less robust. And finally, here in the most severe example, we have a significant amount of frothy secretions accumulating in the inner arytenoid space as well as the piriform sinus bilaterally. We see residue accumulating from a previous swallow, airway invasion, a lot of residue after the bolus is swallowed initially, a present but ineffective throat clear and cough response. And when we compare this to the cough, so in both examples, the point being that as we experience this progressive change in upper airway clearance and dysphagia with weakness of the muscles, greater bolus inefficiency, and poorer airway safety, we also see this decline in respiratory and upper airway defense. So resulting in poor secretion management and airway clearance as these deficits continue to evolve. So the speech language pathologist in the multidisciplinary ALS clinic. So again, returning back to all of the things that we're responsible for throughout the course of a clinic visit. For those of you who are not directly involved in multidisciplinary ALS clinic care, the way that with all of the disciplines that need to see these patients throughout the course of their visit, every provider is limited to about a 20-minute visit on average. Some places it's actually a little bit shorter. Some people get a little bit more because the dietitian and speech language pathologist may go in together, resulting in like a 30 or 40-minute time block, but 20 minutes on average to assess all five of these domains. And you think about a bulbar onset patient that may be experiencing all of these things simultaneously, with quite a bit of change in between visits. So multiple diverse domains to assess during a 20-minute time block. These patients typically come back every 3 months for reevaluation, during which time you may see a significant change in function. So patient and caregiver education is really important early on, in anticipation that these things might change quickly. It creates a high pressure workflow. If you have a really good team, which we definitely do, you have to divide and conquer, but you really are reliant upon evidence-based screening tools with a very high yield. Meaning we don't want to incorporate a lot of things that don't give us a lot of bang for our buck. We want to make sure that we're incorporating the evidence that is strongest and will give us the most return on our investment and on the patient's time and effort. So with the focus on our tool requirements, which are the things that I'm going to refer to, that us incorporating into our screening metrics, need to be non-invasive. They need to be accessible, compared to being expensive. They need to be have a balance of accessibility, robustness, cost, and invasiveness, depending on the resources that are available within your clinic space. And the things that we're going to consider are the time constraint, of course. They need to be rather quick. Prioritizing across the multiple functional domains, making sure that the tools are evidence-based, and taking into consideration that you're working with 10 to 12 other providers that also need to see these patients, in that high workflow setting. So I'm going to go through systematically the different domains of bulbar screening. And I just put the definition of a screening tool here because I think sometimes the lines between screening and assessment get a little bit blurred, especially within the multidisciplinary clinic. And it's really best evidence-based to screen during these visits and then triage outside of the clinic for further assessment. So for example, if you find that someone does poorly on a few of the screening tools, then you triage for a communication evaluation or voice preservation, or you triage to a FEES or modified barium swallow study, depending on the results of these screening tools. So the purpose of these are to detect diseases early when they are easier to treat, reduce severity, or monitor risk factors and decline. So the first domain we're going to talk about is dysphagia and airway clearance. There are four tools that have good evidence, either within ALS or preliminary evidence within ALS that would indicate that they would be appropriate to use in the context of a multidisciplinary clinic. The first one is lingual strength testing. And I'll preface this by saying we're going to go through all of the things that have the most amount of evidence and then talk about the pragmatic nature or non-pragmatic nature of their inclusion in clinic. So these might seem more research-based if you're not familiar with them, but on the latter half of this presentation, we're going to talk about, if you don't have access to an IOP and lingual strength training, what are things that you can do to still get at this area and assess it in a robust way, and then eventually work toward getting these tools if that's something that your clinic can do. So we'll continue with that notion. So the oral performance instrument is a measure that uses an air-filled bulb to assess the maximum anterior isometric lingual strength. So it's a very easy test. The device itself is rather expensive to maintain because the tongue bulbs are very expensive. There are other similar devices like the tongometer that are a little bit less expensive and can also be explored as ways to get at this measure. But you'll place the bulb on the anterior portion of the tongue. The patient raises the tongue up to the alveolar ridge and does a hard isometric anterior press. The 3-ounce water swallow test is probably the most well-known swallowing test that we have. The patient drinks 3 ounces of water without stopping, and airway safety is assessed by coughing or throat clearing, inability to complete the test, or wet, gurgly vocal quality. We also have peak cough flow assessment. This can be done with the perceptual ratings that we just listened to across those different upper airway examples, as well as using a very inexpensive peak cough flow meter with disposable mouthpieces. Again, we'll get into the specifics of this in just a minute. And the test of mastication and swallowing solids. This uses normative data based on mastication of a saltine cracker to assess masticatory efficiency, bolus formation, and there's both a bite measurement as well as a durational measurement of how long it takes to complete from start to finish. And for each of these metrics, there is evidence that exists in ALS, whether it be cutoff values or ways that we can triage and kind of incorporate this information into our bulbar screening. So, for example, for the IOP, we have cutoff values that are associated with unsafe swallowing, preclinical changes in swallowing function, as well as bolus inefficiency. So here we have 25, 26 kilopascals and 33 kilopascals for unsafe and inefficient swallowing, respectively. The 3-ounce water swallow test is an assessment, of course, of airway safety. There's very, very variable sensitivity to identify aspirators in ALS. The 3-ounce water swallow, it has much more robust data in head and neck cancer and stroke patients. But the two studies that we have in ALS has sensitivity as low as 55%, meaning that just because they cough or just because they don't cough, it's like chance as it is in terms of the accuracy of the test. The reason that I still include it here is because I think it's a very good indication of other components of swallowing, whether or not they can finish the test because of breath support. So I don't necessarily rely upon the traditional failure criterion, but rather as an observatory test, whether or not they complete it. If they can't, why? Can they not hold the cup? Do they need a straw? Is it because they don't have enough breath support? So I think it gives a lot of other information as a bolus trial, other than the 3-ounce water swallow criterion. The peak call flow assessment is a measure of physiologic airway defense capacity. There are cutoff values of less than 270 liters per minute. The reason that 270 is used is because once patients developed an upper respiratory infection, the cough flow dropped to about 180 liters per minute, and that was ineffective in clearing secretions from the upper airway and lungs during the upper respiratory infection. This data is based off of single study that's relatively old, but it's something that we use also in insurance guidelines to recommend the use of cough assist and some upper airway early bulbar interventions. The test of mastication and swallowing solids is a validated test out of Maggie Lee Huckabee's lab, and it's again, a great test to look at bolus efficiency for chewing. We have some preliminary data looking at patients with no reported swallowing problems at all, showing that their masticatory duration was significantly longer than patients with um, spinal onset or prolonged mastication in early bulbar onset patients compared to spinal onset patients, neither of which had reported swallowing problems. The second domain that we'll talk about is motor speech and communication. So this is a great figure by Dr. Jordan Green looking at all of the subsystems that support speech. And I think it's nice to differentiate them in this way because we know that in ALS, every single subdomain is affected, but not always at the same time and not always in the same pattern for all patients. So the intervention can be targeted kind of depending on which speech subsystem is most effective. We have a few tasks that can be relatively easily incorporated into clinic. I think probably the most common is the sustained phonation and the standardized reading passage. And in ALS, again, we have evidence kind of describing the use of these metrics. So the sentence intelligibility test is a reading of 10 sentences out loud. The incorporation of this particular test in clinic is probably the least feasible because it requires, at this point, it requires a offline rating, which if you're seeing 10 to 15 patients a day, you're not going to be then doing some offline ratings for sit testing. Um, but it's good to know that if you are, triaging to a full assessment, this is something that you can incorporate and you can compare the individual patient's decline per month and provide some sort of prognostic information about when they may lose the ability to communicate. The sustained phonation task is a nice respiratory metric to use. And in one of our studies, we found that it was actually had excellent discriminant ability to detect changes in the peak cough flow and good discriminant ability to detect changes in forced vital capacity. I find this to be a really useful measurement to use in our telehealth evaluations and therapy visits, especially during COVID. This was something that we really relied on because there were very few things that we could do from an assessment standpoint. So sustained phonation, just having them hold out the ah sound for as long as they possibly can and recording the duration. No tools needed, which is that's a nice feature of that particular test. The standardized reading passage, in most of the literature that's published, they use the bamboo passage. This is a 99-word passage, and with that, they have speaking rate normative data available. So control or healthy control individuals should be able to read this passage in about 160 words per minute or greater. Um, the reason that we like using the bamboo passage is because there's actually a standard decline per month. So in bulbar onset patients, about 4 words per month decline. So if you're seeing someone, every 3 months, we can anticipate that their words per minute may decline around 14 words from time to time. And if it's faster than that or slower than that, it helps us provide some prognostic information to the patient and caregiver about doing things like voice and message banking early, the amount of time that they may have before their voice is lost. And we can also compare that to our spinal onset patients in which the word per minute decline is much slower. It's about 1 to 2 words per minute per month. Um, and I think that's very useful information. One of the most common questions that we get in clinic is how fast these functions will will decline once the decline starts. And while these are averages, and I just showed you the screen of all the different phenotypes and the progression rates that may differ, I always provide this information with a little bit of a caveat that we don't know for sure, but once we get a few data points for each individual patient, we can provide some greater specificity in when these milestones may be met. Also helps to improve the timeliness of our interventions. So one of the cutoff values that's used for AAC intervention, whatever that looks like, whether it be a speech generating device, an alternative access method, is less than 120 words per minute. And this is a cutoff that we use to just start talking more seriously about these evaluations. And if we have context around that, meaning, we've been seeing this patient for a year prior, we know that they're decreasing 12 words per minute per month, meaning they're a much more progressive, much more aggressive declining patient, then we might have these AAC conversations a little bit earlier compared to a spinal onset patient that's hardly changing over the course of 6 months. So patient-reported outcomes, we have quite a few with high yield. These questions are these scales are relatively short. The Center for Neurological Study bulbar function scale being the longest one. It has 3 sections of 7 questions each, looking at salivation, swallowing, and speech. Um, and there are, again, as with the previous slides, there's good evidence in ALS to provide us with a little bit more information about how to triage different things. For example, looking at the ALS-FRSR bulbar subscore. So again, that's that standard scale that we're using, looking at disease progression. The bulbar subscore looks at questions 1, 2, and 3, which are speech, swallowing, and salivation. And several studies have looked at different cutoff values and kind of how they identify different needs. So for example, a bulbar subscore, which is out of a total of 12, if this is less than 8, it had demonstrated good discriminant ability to identify patients requiring feeding tube nutrition, with a sensitivity of nearly 90%, which is very high. So it helps not only provide the patient with information, but to start the conversations about these early interventions so that these things that are ultimately going to be recommended, things like feeding tubes, we can start the conversation early and see if the patient is even interested in incorporating that into their journey. The Eating Assessment Tool 10, a very well-known scale across several patient populations. In ALS, we've shown that a score of greater than or equal to 8 demonstrated 86% sensitivity in identifying aspirators. So patients that had material go down below the level of the vocal cords and either could clear it, a PAS of 6, could not clear it, a PAS of 7, or silently aspirated, a PAS of 8. And then the dysphagia and ALS scale, or the dials, looking at, again, at predictive of PEG 2 placement within 6 months with scores of greater than or equal to 6. We also use a salivary management or secretion control scale. Secretion burden can be very high in these patients, particularly the bulbar onset patients. So having something that we can characterize their responsiveness to treatment is really important. I would say secretion management, we probably have the most options in terms of pharmaceutical treatments that it's usually a cocktail of treatments that help manage the secretions, and they always seem to be different for everyone. So looking at, a validated scale before and after atropine drops or glycopyrrolate or amitriptyline, you can really tell if what drug is helping the most, if it's changing the consistency of the secretions, if we need to talk about a little bit more about hydration. But as patients come back from month to month, if we're doing some sort of standardized salivary management score, it's really helpful to see what drug is helping the most. And the final domain of bulbar screening that I'll talk about today is oral health and hygiene. I have this schematic here. I think most of the research available is focused on Alzheimer's disease, where these periodontitis development has been associated not only with the onset of Alzheimer's disease, but also with the rapidly progressive nature of the disease. Also been shown in patients with Parkinson's disease as well as stroke. So just the really bi-directional relationship between the health of our brain, the health of our mouth, and the onset and progression of these neurodegenerative diseases. And looking at the impairments and kind of the oral microbiome and how this is associated with decline across all of these different systems. And when we look at kind of John Ashford's schematic of how bacterial aspiration pneumonia occurs, poor oral environment conditions can be one of the number one culprits, as well as impaired airway protection and frailty. And patients with ALS check all three of these boxes, putting them at very high risk for aspiration pneumonia. Oral health and hygiene kind of represents one of the most actionable things that we can do in clinic, meaning we can make a recommendation and very quickly change the health of the oral microbiome with a few simple changes. Um, and we recently did some work looking at exactly this. In our clinic, we had 63 patients with ALS come in. We worked with the College of Dental Medicine during the multidisciplinary clinic to do an oral health and bulbar assessment. And I'm just going to quickly present some of the results of this because it's kind of hot off the press. We just had this published, and I think it's really good to say not only did we find this information, but we were also able to incorporate this screening directly into clinic, which I think is one of the best types of research to find. Not only did we find something interesting and useful, but we can actually do it in the clinic. Um, so we looked at oral health outcomes in a validated way. The dentist came in, did an oral health screening that was pretty involved with the purpose of seeing if we could do an abbreviated screening and get the same results. So that's kind of what the study was looking at. In our ALS patients, we saw greater oral bacterial load, a significantly greater inflammation, and very poor gingival disease with a lot of inflammation and periodontal bleeding. Our patients with significant upper extremity weakness had significantly worse oral health. We actually hypothesized that it would be worse in our bulbar onset patients, given the fact that they sometimes have difficulty opening the mouth all the way. They have a lot of secretions that are difficult to get around, especially when they're drooling while trying to brush their teeth. But when we analyzed the results of this data, it turned out that upper extremity weakness was by far and away the primary predictor of poor oral health. The primary predictor of higher gingival index and plaque in the tooth was a lack of dental insurance, which again is not necessarily surprising, but also not something we always ask about. The recency of professional dental cleanings and just trying to emphasize from a patient and caregiver education standpoint that this is something we really need to focus on because it's possible that it has an impact on the way that the disease progresses, especially in the bulbar area. Additional contributors included disease severity, age, and care partner status, meaning that people with more advanced disease, older age, and lack of a care partner also demonstrated worse oral health. Not necessarily surprising, but good evidence to have kind of borne out in the literature. Feasibility, this is the component that I was referring to earlier. So the dental screening that we did took about 18 to 22 minutes on average. And this included a full mouth assessment. And there is a validated 6-index tooth approach where you can just look at the health of 6 different teeth in the mouth. It takes about 5 minutes. And when we looked at the associations between the whole mouth and just these 6 teeth, they were nearly 1.0. So we can just look at these 6 teeth and provide some recommendations on oral health and kind of focus on improving that very actionable component of bulbar care. All right, so given all of this evidence, a lot of information, some things that seem super doable, other things that seem a little out of reach, either because they're expensive or appear to be inaccessible. But how can we incorporate this evidence into clinic? We've been working on what we're calling a tiered screening and assessment tool. So the next slide I'm going to show you has a lot of information on it, but I'm going to kind of systematically walk through what we've been designing kind of for the past year or so. So we started an SLP working group through the Network of Excellence for ALS, which is referred to as NEALS. And this tiered assessment tool, the whole design of it is to more systematically evaluate bulbar function in multidisciplinary ALS clinics using a framework called OMERACT. If you're familiar with the WHO classification or Cosman guidelines, OMERACT is another based framework with a primary goal of identifying endpoint outcomes and relying on multiple different stakeholders. So in this group, we have researchers, we have clinicians, we have people that do both. And in a very iterative way, we've refined these different domains and looked at literature reviews for each one of the outcomes that I just kind of presented. And using this framework, we have three different components. The core area, so this is the bulbar function, bulbar motor function, speech, swallowing, airway protection and clearance, as well as cognition. These are the more pathophysiological manifestations, the things that we would actually measure in clinic. We also want to consider overall bulbar function in the eyes of the patient, functional communication, their participation in eating and drinking, how saliva is impacting their quality of life, as well as the psychosocial impact. And in both core area 1 and core area 2, we have outcomes that fall into each one of these tiers. So tier 1, the point of the tiers is to really focus on the resources that are available in your respective clinic. So maybe you're in a newer clinic, you're trying to get it off the ground, you have minimum resources, you don't really have instrumentation. You need things that are very feasible, very low burden, and can be administered very rapidly. The tools that would be in core area and core area 1 and 2 for that particular tier would be very minimal. Then in tier 2, we're looking at things that potentially require training or instrumentation. And then in tier 3, kind of like the research grade, maybe it's a certified treatment center of excellence and you're required to have research involved. So you need these instruments to be able to meet that criterion. So I'm going to provide a few examples of this and then show you a working model, kind of like the meat and potatoes of the tiered tool that we've been working on again over the course of the past year or so. So for example, when looking at core area 1 and considering bulbar motor function, we have tier 1. You can do things like a cranial nerve exam, an oral motor assessment focusing on observation of atrophy and fasciculations within the tongue, as well as movement characterization, so range of motion, symmetry, and speed. This would be much like your standard oral mechanism exam, with a focus on areas that we know to be impacted in ALS. Can they maintain intraoral pressure? Because velopharyngeal function is often one of the first thing that's impacted. Um, And then in tier 2, we're moving more toward a standardized assessment. So something like the ALS bulbar dysfunction index. This has a cranial nerve subsystem that just has a rating criterion. So you're putting numbers to your observations, 1 through 5, 1 being not at all affected, three being somewhat affected, 5 being either, depending on what you're looking at, maybe if you're looking at the tongue, complete paralysis, or presence of severe fasciculations. So things that can potentially change over the course of time because you have a standardized way of measuring them. And then in tier 3, looking at things like the IOP or tongometer to measure lingual strength in a standardized way and have these outcomes that are a little bit more objective and can be quantified throughout the progression of the disease. So currently we're working on looking at tier 1, tier 2, and tier 3 across all of these different domains that I just spoke about, the swallowing domain, your speech domain, patient-reported outcomes, as well as oral health and hygiene. And considering the core area 1 being the pathophysiological presentation and the core area 2 being how does it impact the patient's quality of life, the caregiver, and impact their activities of daily living. So here we have an example of some of the screening that we're working on. So tier 1 being this first column, feasible in most ALS clinics, the point that there's no instrumentation and it can be administered fairly rapidly. Tier 2 being slightly enhanced, requires additional training and potentially some simple instrumentation. And then tier three, being the advanced research or certified treatment center of excellence criterion and some of the examples that are included here. So the idea is that if you're in tier three, you're kind of doing some of the things that are also in tier one and tier two, and then incorporating this more potentially more quantitative or piece of instrumentation that allows you to more sensitively track change over time. Um, so these are the things that were incorporated in the last few slides. All have some evidence in ALS to demonstrate that they would be worthwhile to include in your multidisciplinary clinic assessment. Um, I'm going to be providing these slides to Tim's Medical University, so they will be available for you to kind of take offline and potentially take with you into clinic if you're starting off in clinic or have, questions about what the evidence suggests we should include. This is the working tool that we will eventually, not eventually, soon, we'll have published um, for everyone to refer to. So takeaways from today, the SLP and the multidisciplinary ALS clinic. Tonight we focused a lot on the screening tools. How can we assess bulbar function in the multidisciplinary clinic? Um, I think we've demonstrated that speech language pathologists are essential in this care, given the onset and progression of the disease. We need to manage communication, swallowing, upper airway function, quality of life, oral health and hygiene. We are very busy in the clinic. Bulbar deficits, particularly dysphagia and dystocia, co-occur in this population and should be assessed and considered together using some of these tools that we discussed. And evidence-based accessible frameworks exist to screen, assess, and monitor bulbar function. And I hope tonight's talk was really helpful in kind of distilling some of the evidence that's out there and putting it in a clinic-friendly way and trying to be pragmatic in our approaches to using this evidence in the best way that we possibly can. Um, I could talk for a whole nother hour about interventions and, once we get this information that from a screening, how do we triage and start different things? Um, so I think I would love to come back and do that, do a part two on how we can incorporate some of these things to start things like expiratory muscle strength training or voice preservation, home speech therapy, outpatient speech therapy. There are so many things that can be done for our patients with ALS. So thank you very much for your Wednesday evening. I know it is late and I appreciate everyone joining. And just wanted to take a second to acknowledge everyone in my lab, Dr. Rocky Garcia and Dr. Unisova, and everyone in the NEALS SLP working group that has helped kind of get this project together. And I'm happy to take a few questions.
Awesome. Thank you. People in the chat are saying yes, please come back for part two.
Okay.
So we'll definitely have to get that on the schedule for 2027. But just quick couple of housekeeping items before we dive into Q&A. If you would like ASHAs to use for this event this evening, just complete the brief survey. I'll put it again in the chat and it'll be sent out via Zoom emails. And then if you would like a certificate of completion, just send us an email at tims-unum@tims.com. There were a lot of requests for the slides. So as mentioned, the replay and the slides will be up on the TIMS website within 48 hours. So let's go ahead and dive into questions. I'll start with the Q&A. So one attendee asked, is EMST recommended to maximize cough strength in this population?
Great question. Yes, it is recommended. The jury is still out on us if it improves cough strength. Maximum expiratory pressure has been replicated throughout 10 years of literature. So, maximum expiratory pressure is the ability to forcefully push air out, kind of mimicking the high velocity shearing forces that are needed for an effective cough. Doesn't always translate directly to the cough testing that we do, but we know EMST also has an impact on pharyngeal muscle activation as well as submental and lingual muscle activation. One of the limitations that we have in the research is it's kind of a double-edged sword because we start EMST very early. It's designed to be an early intervention. And a lot of the studies that we are, the randomized control trials that we've had, we've started EMST prior to swallowing being a problem because we know the trajectory of decline and we know things are going to change. So we're not really going to wait until swallowing problems occur and then start. That's a very reactive approach. Um, but we know the physiology that's impacted with EMST that's been shown in healthy people with fine wire EMG. It activates the submental muscles, it activates the genioglossus, it activates the thyroarytenoid, responsible for adduction of the cords. So we have the underlying pathophysiology that we know is impacted during the EMST training. And we know we're getting a cross systems approach, a cross systems effect from the respiratory and upper airway function as well. So yes, EMSD is recommended as an early intervention. There's, decades worth of literature that we can, provide to our neurologists and the people that we need to have discussions with about incorporating these interventions. It's very safe, and it is effective in targeting those muscles.
The next question is, are there any clinical quote unquote hallmarks of dysphagia in ALS that would help identify patients with early dysphagia symptoms but no official diagnosis yet?
So there does appear to be a rostrocaudal, meaning it starts kind of in the oral phase of swallowing and then progresses pharyngeal. Especially in our bulbar onset patients, the tongue is impacted first. We do a lot of IOP in our clinic, the anterior lingual strength testing. And even in patients with no reported swallowing problems, they can have subclinical changes in lingual strength in the 30s and 40s in kilopascal, which is pretty reduced. It's about 30%, 30 to 40% of what you would expect for a normal healthy person. So we find changes in mastication first. And I think that's a really important notion because it contributes to swallowing and eating related fatigue, longer meal times. People start to get frustrated, eat less, weight loss becomes a problem. So I think one of the hallmark features and one thing that you can look for is problems with chewing. I also find people to be not that good at being aware of this. So I think that something like the Tomas, it doesn't have to be a saltine cracker, but anything that you can give them to kind of challenge them and highlight the fact that it is more difficult than they anticipated. Sometimes they're using really saucy foods and a lot of gravy, or their loved one is cutting the food up really small, and they're doing a lot of these compensatory things that might be masking how much more difficult chewing has become. So really doing a little challenge with a bolus trial, I find opens up the floor for some conversation about inefficiencies in the oral cavity.
This participant asked, within your screening measures in clinical setting, are you incorporating all screening measures and interpretation and discussion with the patient and their family within that 20-minute time frame? And if so, how are you delegating all of that?
Yes. So the goal is yes. The goal is yes, we are doing all of these things in the kind of tier three and providing patient and caregiver education. In a patient who comes in with a spinal onset and almost no bulbar involvement, these things can be done in 10 minutes. And then the patient and caregiver education is really just, hey, things are looking pretty good right now. We're going to continue to do these assessments each time you come back. We have a lot of information that helps us predict how they're going to change, what that's going to look like. But right now, we're just going to talk about voice preservation or making sure that your weight stays stable in conjunction with the dietitian. If a patient with a significant amount of bulbar impairment comes in, we do all the measurements. And sometimes we have to prioritize what is most impaired and focus on that. Um, so it's definitely something that it's almost like branching logic as a clinician. When someone comes in, you really have to kind of think about what is going to be the safest, what is kind of the most harmful. and what is something that you can actually change quickly. So, for example, something like oral health and hygiene. It's a relatively quick conversation. Walk me through how you brush your teeth. If they're not brushing their teeth, just admitting that and making sure that we focus on brushing teeth twice a day. So, a lot of the education that we do doesn't have to be this big, long conversation. It's sometimes very quick, kind of bulleted points um, about what we're going to tackle.
We have a ton of questions that I know we won't get to in 6 minutes, so I'll rapid fire ask you a couple that should be faster for you to
Okay.
answer. Someone asked, you mentioned an alternative if you don't have access to IOP. Could you repeat what your recommendation was?
So if you don't have access to IOP, it's the tier the when we talked about kind of the tiered assessment tool, um, the tongometer is a good alternative that's significantly less expensive than the IOP. And while the data have been compared between the IOP and the tongometer, I think the important takeaway that is if you're always using the tongometer, you could just compare the values within the tongometer, even if there are differences between the IOP and the tongometer. The point is that we're objectively and trying to assessing these things and quantifying them within the same patient using the same tool. That's where I think we have to be really pragmatic in our considerations and in our interpretation of the research data.
One attendee asked what peak flow meter your clinic is using.
We use the mini right, MINIWRIGHT PF 100. It's like $19 if you order a couple of them, and then we have a one-way mouthpiece that goes on the top of it, that has a bacterial filter in it. And the mouthpieces for a box of 200, I think they're like $50.
Um, Someone asked, are traditional swallowing exercises beneficial for this patient population with fatigue being a factor?
Um, I always I blanket questions like that are so hard to answer. So if a patient is demonstrating a significant amount of lingual weakness, then I think lingual exercises can be helpful. There's certainly no evidence that they're harmful. There have been exercise studies both in animal models and in humans, in pretty impaired patients, and we have not found that exercise has hastened the progression of the disease in any way. So I think I, depending on the impairment that you see, that would kind of dictate which dysphagia exercise you would want to do. We've recently started incorporating a lot of lingual strength training exercises, and we're kind of going to see what comes of it. But in the experience that we've had in the few patients that we've done, nothing has been harmful. We've been able to strengthen the tongue, and it does not always have an impact on function, is what we found.
There were a ton of questions about EMST, so I'll take this one and then this will probably get us to that top of the hour. And I'm sure people will want to hear your thoughts on EMST in part two. But this person said, what are the guidelines and thresholds for recommending EMST? For example, in your opinion, is there a cutoff or specific inclusion criteria?
So outside of the regular contraindications for EMST, from an ALS specific standpoint, we continue EMST until mechanical ventilation is used, or cough assist. So it's a balance between the patient's time and effort and the return on the training. So EMST is certainly an early intervention when they don't have any breathing problems, when they have very early bulbar involvement, you can continue expiratory muscle strength training. There comes a time when there's going to be more benefit from a non-invasive ventilator and a cough assist than the EMST. Although they do target different things, the cough assist is a much more aggressive therapy for clearing the lungs and helping with secretions. So we have patients that continue EMST while they have the cough assist. But generally speaking, when we're considering their effort and their time, once their maximum expiratory pressure, which is a measurement that we take in clinic, reaches about 50 centimeters of water, we stop training because that means that the EMST device is set at 25. Um, and their cough assist machine is typically set between 25 centimeters of water and 40 centimeters of water. So if they're going to be doing both, we don't want to be wasting their effort and causing increased burden from an exercise standpoint.
Awesome. Well, thank you so much, Dr. Tabor Gray, for your expertise and your time this evening. People are, mentioning it in the comments that this is the best ALS presentation they've heard in 25 years, and people are requesting that you come back to talk more
Oh.
about this. So thank you again for your time, and thank you all for joining us this evening. I know we did not get to a ton of questions that you had, so be sure to stay tuned for part two. And like I said, the replay and the slides will be up on the Tim's website within 48 hours, and all of the links will be sent out via Zoom email. So thanks again. And I know Dr. Tabor Gray has some podcasts out on this topic, so be sure and check out those resources as well. With that, we will wrap up for the night. Thank you all for being here, and we will see you later. Bye, everybody.
Thanks, everybody.